Thank you for hosting me on a second sabbatical. We have certainly learned a lot from you over the past 10 to 12 years, and I hope there's some interesting parallels in our work over in Australia. So I first got involved in translational genomics research back in 2013, which makes me sound a little bit old, with the establishment of the Melbourne Genomics Health Alliance. Obviously, the 100,000 Genomes project had been announced. We all felt terribly jealous. Unfortunately, no such money was coming our way. So what happened in Melbourne was that 6 of our hospitals and research institutes got together, pulled a little bit of cash, and we tried to get genomics off the ground. And that has very much characterized the bottom-up approach to genomics implementation in Australia. So with that small amount of money, what we wanted to do was to examine the role of exome sequencing as a first-tier test and to demonstrate its value in clinical care. So this was at a time when genomic testing was very much reserved as a test of last resort and typically occurred in the research setting. So we were very clear we were not going to do any discovery research, but rather we would concentrate on multidisciplinary prospective evaluations of a number of cohorts to try and build the evidence for how genomics should be integrated in the Australian healthcare system. I got to run one of the very first cohorts that were funded through Melbourne Genomics. So this was examining the role of exome sequencing as a first-tier test in a small cohort of babies with suspected monogenic disorders. So what we did for this study was to ask our colleagues to continue investigating these babies in the way that they usually would, whilst we ran exome sequencing in the background. Through that study design, we were able to demonstrate that exome sequencing was actually 5 times more effective at achieving a diagnosis compared to usual care. We saw much more clinical utility from the results. Yes, it cost more to do this upfront, but actually if you look at the metrics such as cost per diagnosis, it is a much more effective use of the healthcare dollar. We followed up this cohort for a period of 2 years after the initial results, and the other really striking effect was that the benefits of diagnosis extended to the whole family, particularly in restoring the confidence of parents to have more children. So in the cohorts of parents who received the diagnosis, they had many more pregnancies in those 2 years compared to the ones that did not. And actually the early termination of pregnancy happened in the cohort of parents who did not have a diagnosis, and that really brought home to us how scared families feel when we don't have answers for them. One thing that we've really excelled at in Australia has been health economics research. To be honest, the main reason for that is because it's been the only way to convince our government that this is worth doing. So this is what collecting cost data looks like on a patient-per-patient basis. This is a 5-month-old little boy who presented with low muscle tone and seizures. We spent 9 months investigating him in the way that we usually would. We racked up a bill of about $12,000. So you need to divide that into 2 to get to the pounds, and we got the wrong diagnosis. The clinical diagnosis that we gave to the family was that of Lee's disease, which is a mitochondrial condition that was expected to be fatal in the next 2 to 3 years, and we told them to prepare for the worst. I still very vividly remember the day that we got the exome data back. This was back in the days of Excel spreadsheets, and this alternative diagnosis stared us in the face of a thiamine transporter defect. So this is a rare metabolic condition that I hadn't heard of before. Turned out to be imminently treatable. The treatment costs less than $1 a day. He was started on treatment, and he's done very well since, although he does have residual neurological disability due to that delay in diagnosis. We managed to diagnose his sister before symptom onset, treat her, and she remains well to this day. Obviously, at this point, we all wished we'd gone a bit faster with this, and obviously no family should have to wait 5 or more years to get the diagnosis. But for a small number of babies and children, time is really of the essence. So 5% of neonatal unit admissions are thought to be due to an underlying genetic condition. Intensive care units are expensive places to stay, so for us it costs around $4,500 a day just to keep the lights on. And decisions in this environment are made in minutes and hours, not months and years. So we thought, how hard can this be? If you just get a piece of paper and write down all the steps involved in a genomic test, usually you come up with this sort of answer. It shouldn't really take us longer than 7 days if we were a little bit more organized. So we thought, well, we got the chance to do that through the next round of funding through Melbourne Genomics. And here we recruited a cohort of babies and children from 2 children's hospitals in Melbourne. We decided not to be overly ambitious and set ourselves the aim of a 3 to 4 week turnaround time. As soon as we started trying to do this, though, we ran into a lot of problems, both at the laboratory and the clinical end. The thing to note about genomics laboratories is that they're really set up to get economies of scale. And really, our lab felt pretty unimpressed by the suggestion they should run a half-empty or empty sequencer just because one baby was sick. At that time, our infrastructure was fairly immature, our team was quite small, and really pushing everyone just to go faster and be more organized just resulted in breaking everything and did not make me particularly popular. There's also a number of clinical barriers to this type of testing, and they're mostly to do with the different patterns of working in intensive care units versus clinical genetics departments. Obviously, medical care in an intensive care unit is provided around the clock, so 24 hours a day, 7 days a week, 365 days a year. That's not really how clinical genetics likes to work. Really, we enjoy 9 to 5 days, Monday to Friday, and expect to have weekends and public holidays off. So for us, that had set up a pattern of interaction where we got many late referrals just before death or discharge, basically because our colleagues didn't really expect us to do anything useful in a hurry. So the first few times when we tried to do this, we got a turnaround time more like 3 months rather than the desired 3 weeks. But we worked through all of our problems, and in this cohort we managed to achieve a median turnaround time of 16 days, and the shortest was 9 days, which is getting to that theoretical minimum. Obviously, we learned a lot of lessons along the way, and these are the two most important ones. This requires whole-of-system change. It's not just about the test. So in the context of rapid testing, yes, there's the rapid test, but actually for a baby to get a rapid diagnosis, you also need early referral from intensive care. When that happens, clinical geneticists need to respond fairly quickly and also make up their minds pretty swiftly about whether testing is indicated or not. And once we've committed ourselves to that path, we also need to be pretty organized with getting consents and samples done. And the second lesson for me has been the importance of getting some runs on the board. So in terms of the laboratory side of things, demonstrating that we can do this and that we can do it consistently so people start trusting us. And from a clinical perspective is finding those cases that really demonstrate clinical utility, because that's what brings people along. And from that cohort, this is kind of the standout case. This was an 8-month-old little girl, previously well. He was admitted to an intensive care unit with pauses in her breathing. She ended up needing a tracheostomy and 24-hour ventilation pretty quickly, and actually continued to deteriorate despite maximal treatment. We managed to get a diagnosis for her and her family in 3 weeks. She turned out to have a riboflavin transporter defect. This is another rare metabolic condition that I hadn't previously heard of. Again, the treatment costs less than $1 a day. She was started on this, came off the ventilator, came out of ICU, and went home. There's no doubt in my mind that we saved her life, and in this cohort we managed to demonstrate that we were able to go 10 times faster than usual just by being organized. We started returning results during the hospital admission so that they started forming part of clinical decision making during that acute episode. Our diagnostic yield stayed about the same. The clinical utility actually doubled. It cost us a little bit more to deliver this, but actually the cost savings are much larger because we started to impact another very high cost intervention in the healthcare system, which is intensive care unit stay. At this point, this got a little bit addictive, and we definitely wanted to go bigger, faster, and better. And we got the chance to do that through the establishment of the Australian Genomics Health Alliance, which has been our national level research collaborative, again tasked with building the evidence for how genomics should be integrated in the Australian healthcare system. So at this point I jumped ship, and in the first 5 years of operation, Australian Genomics ran a number of rare disease and cancer cohorts where we evaluated the role of genomic testing across a range of clinical indications. And these results have now been published. I got to run the next cohort, which was called the Acute Care Genomics cohort. And for that, we set ourselves 2 goals. Now we felt a little bit more ambitious, so we wanted to go to under 5-day turnaround time, and that's calendar days, not working days. By that stage, we'd realized the whole laboratory pathway would actually need to be redesigned. So we decided to go to 24/7 sample processing, so that was goodbye weekends. And we decided not to worry about sample batching, bought some shiny new equipment, and worked harder on being organized. The second thing that was really important to me by that stage was to make sure that this is something that's available to every baby and child who needs it in Australia, not just in one or two of our best children's hospitals. So we leveraged the Australian Genomics Research Network in order to recruit from all of our children's hospitals and a large number of our maternity hospitals. By that stage, I'd also met with an implementation scientist and actually realized there was a whole bunch of theories and empirical evidence about how you should go about implementing something in the healthcare system if you wish to be successful. So we actually had a very structured approach to implementation this time around. As always, a very strong emphasis on communication, having formal onboarding processes for all of our sites, and building a lot of feedback loops between our clinical and laboratory teams to make sure that everyone comes along on the journey. We put money against an educational program for the intensive care physicians to make sure that we're finding the right patients at the right time. Had a fantastic team of project champions and leaders across all of our sites. Worked hard to get nationally agreed patient selection guidelines and put a lot of time and thought into things such as logistics and efficient workflows. So this one worked like clockwork, and we tested 450 critically ill babies and children. First 2 years we did exome sequencing. Finally, we were able to afford genome sequencing, so we switched over to that for the second 2 years. Throughout this cohort, we managed to achieve a turnaround time of just under 3 calendar days. There's only a handful of laboratories capable of doing this worldwide, and we feel pretty happy that we're able to do it at a national level, and our diagnostic yield stayed just about 50%. The results of our exome cohort were published now 5 years ago in JAMA, and the results of our genome and multi-omic cohort in Nature Medicine a couple of years ago. Throughout, we have been very careful to document clinical utility, so we saw changes in management in 77% of those diagnosed, and in 60% those can be characterized as major impacts, including being able to access precision treatments, influencing surgical and transplant decisions, and influencing the very difficult discussions that sometimes have to be had about the overall goals of care. These cohorts have been evaluated in every conceivable way, and I don't really have time to go through all of that just now. But one of the most important things that we wanted to ascertain is how do families feel about these results, and do they think that they make a difference. So these are some of the free text comments that were left for us as part of our surveys, which I can't read on the screen. So this is what families had to say. There is so much angst waiting for results, and this is compounded by caring for a very sick child. Having the test come back quickly lifted incredible weight and stress from our shoulders. Obviously, many of the conditions that we diagnose are extremely rare, and there might not be another family in Australia. We could contact people around the world looking for help. The families where we provided access to precision treatment were understandably very grateful. The results determined the treatment to save our child's life. But actually, the largest number of comments we had left for us were from families whose child had died, and they all said the same thing. It was important to us that our child didn't suffer any longer than he had to, which meant not unnecessarily prolonging his life. Obviously, this is very important, but when it comes to talking to government, it's all about the money. So the question that I get asked is, how much does this cost, and is it cost effective? Not only is it cost effective, it is actually cost saving. So we've used real hospital data from that first Melbourne Genomics Rapid cohort to model a number of scenarios. So if you just do this with a 2 to 3 week turnaround time, you save money. If you speed up the laboratory part, you save more money. If you change clinical practice in order to get the testing happen early and the clinicians hold off on a bunch of other things, you actually save more money. And the best scenario of all is where you influence both clinical practice and laboratory practice, and you save the most money. Overall, a cohort like this is a beautiful illustration of how we can use this research on one hand to build the evidence for how something should be implemented into clinical care, whilst at the same time making the data available for secondary research. And this cohort has been particularly good in terms of gene discovery, with more than 10 new gene discoveries arising from this alone. The last 10 years have been a very exciting time to be working in clinical genetics and genomics. There's no doubt that we're now so much better at providing accurate and timely diagnosis to many more families that we see. What has also been really pleasing to see at the same time has been this explosion in precision treatments, ranging from treatments for relatively common conditions such as cystic fibrosis and SMA, right down to N-of-1 conditions. And when it all comes together, it is a fantastic thing to be part of. This is another one of our patients from the acute care cohort whose story was featured in the New Scientist. He is basically the youngest patient in Australia to be diagnosed with Gaucher disease and to be started on enzyme replacement therapy. And we managed to do all of that in the first week of life, and he's done incredibly well. And obviously we all feel very happy with these sorts of outcomes. But it would probably be a little bit dishonest of me to just stand here and show all the happy cases from these research studies. There is still more work to do, and sometimes a diagnostic approach, regardless of how fast and how organized we are, it is still not enough. So this is another 9-month-old little girl who was admitted to another of our children's hospitals with depressed conscious state and a rapidly evolving purpuric rash. To anyone with medical training, this looks like meningococcal septicemia. My colleagues were actually really smart and realized she was running an atypical course, referred to for genomic testing on day 5 of her admission. We had a result for them on day 8. She had a potentially treatable metabolic condition and unfortunately died on maximal treatment on day 10 of her admission. And the reality is that if we wait to provide these diagnoses until there's already multi-organ failure that has set in, it's actually really hard to reverse that and to avert disability and sometimes death. And it is both the big wins as well as the tragic cases that have provided a lot of motivation for many people around the world now to explore the idea of perhaps integrating genomic sequencing as part of newborn screening so that we are getting these diagnoses before babies become unwell. And obviously there's a large number of these studies running around the world at the moment, including the very large generation study here. I got to co-lead a much smaller study in Melbourne called the Baby Screen Plus study. We have just finished recruitment of a cohort of 1,000 newborns, where we have provided clinically accredited whole genome sequencing for just over 600 severe early onset conditions. Because our cohort is much smaller, our primary outcome measures are feasibility and acceptability. We're in the middle of putting our results together, but just, I guess, a couple of highlights. We've managed to get to a time of report of just under 14 days, which is approaching the turnaround time of standard newborn screening for us. We have identified 16 high-chance results, and of those, only one was identified through standard newborn screening. The results roughly fall into 3 groups. On the one side, there's the fairly low impact results where we've just provided advice to families about agents to avoid triggering illness. In the middle, there's a group of conditions where we've linked babies and families with surveillance to try and identify complications of the condition at an earlier stage. And then we had 2 high-impact results. The first one of a glycogen storage disorder. This baby turned out to have congenital heart disease that was completely unrelated and was in fact scheduled to have surgery at our hospital 2 weeks later. So knowing about this underlying condition allowed us to plan the surgery in a different way to avoid episodes of low blood sugar. And the second one is of a severe immune deficiency. That baby has gone on to have a successful bone marrow transplant and has now gone home. So I'm really excited to see what the next 5 to 10 years bring as we roll out the benefits of genomics at population scale. And finally, I'd just like to say genomics is obviously a big team sport, and probably the best thing about the last 10 to 12 years has been the opportunity to collaborate with so many wonderful people, both nationally and internationally. Thank you.